I'm Amy DeZern. I'm the Vice Chair for Heme Malignancies and a Professor of Oncology here at Johns Hopkins. I love taking care of patients with all flavors of myeloid malignancies, namely MDS, aplastic anemia, and clonal hematopoiesis. I run a lot of clinical trials in those three spaces. This is a small letter from what is a really powerful study. So, a challenging area in clinical medicine is the diagnosis and follow-up of patients who are cytopenic. And bone marrow biopsy is a very painful intervention, but historically, it's been the main way we've been able to follow the natural history of patients with myeloid disorders or other blood cancers, such as clonal hematopoiesis, clonal cytopenias of undetermined significance, these at risk for MDS conditions, and then, of course, MDS itself. In our paper from the National MDS Natural History Study, we reported comparisons of somatic mutations with their variant allele frequency, or as I explain it to patients, the mutation dose, in paired samples from the peripheral blood and from bone marrow samples from the same patient. And we wanted to understand the reliability of following that sequencing in the peripheral blood to try and avoid those painful bone marrow assessments in patients where we can, or at least make an accurate estimate based on the data that we find in the peripheral blood. What we showed was what you probably would expect, that most mutations are shared between the bone marrow and the peripheral blood, and also unsurprisingly to me, the variant allele frequencies in the bone marrow are higher than the variant allele frequencies in the peripheral blood, even for the same mutation. And it looks like from our data, which is supported by other reports in the literature, that if the mutation is with a variant allele frequency of less than about 10%, you really can't see it in the peripheral blood, and you do need that bone marrow to follow it. So it really is a great time in medicine in general where we have so much amazing technology that we can detect all this aberrant clonality in the blood, and it can be annotated and correlations made with all kinds of diseases, not just blood cancers. But I think specific to MDS and the blood cancer space, we're still really at a unique time where we're trying to study prospectively what are clinically relevant thresholds for clonal hematopoiesis in the blood and how we intervene earlier in those human beings to change the natural history of their disease and hopefully extend overall survival if we think that their evolution to a myeloid malignancy is going to be what limits their life. There's some neat new scoring systems trying to predict higher risk clonal hematopoiesis and who's more likely to evolve to a full-blown MDS or even AML. And so it's a really unique time where we have those technologies, and now we're tying it back to the clinic and making sure it makes sense for patients. So it's a very happy time in myeloid malignancies as we blend the science and the bedside clinical care. Just that the blood is a very sensitive organ. We'll often be able to pick up things based on what's going on in the rest of the human being systemically, and hematologists have a role to help the patients and their providers understand that. We look forward to adding more science from our data.